This is a case presentation of osteomyelitis with Alcaligenes Faecalis in a non-diabetic patient. This case is significant because we are presenting the first known case of this organism causing osteomyelitis in an immunocompetent host. Osteomyelitis with Alcaligenes faecalis has only been reported in the literature 4 other times. In those cases, 2 of the patients had diabetic foot ulcers, and the other 2 patients had meningomyocele and presented with osteomyelitis after operation. Our patient had neither of these conditions, as they have no history of immunodeficiency, and his hemoglobin A1C was 5.8. Our case begins with a 56-year-old African-American homeless male with a recent history of amputation of his right hallux secondary to a gangrenous infection. At that time, pathology was inconclusive, and at his first post-operative follow-up appointment, his wound was dehisced and several maggots were found within the wound bed. His foot was properly cleaned, and the patient was counseled on the importance of antibiotic compliance and daily wound care. However, the patient did not pick up his antibacterial prescription and was lost to follow-up. However, approximately 6 weeks afterwards, the patient was readmitted to the hospital for an unrelated complaint, a perforated gastric ulcer secondary to alcohol and cocaine use. At that time, his foot was a secondary issue. However, when asked about the foot, he stated he was wrapping it in toilet paper and did not have proper wound care protocol. The wound care team was consulted, and upon a closer inspection, they found a poorly granulated wound bed with warmth, erythema, and purulent discharge. An X-ray showed a new aggressive erosion within the medial aspect of the first metatarsal head with associated soft tissue swelling consistent with acute osteomyelitis. He was immediately started on broad-spectrum antibiotics with vancomycin and zosyn, and podiatry ended up performing an incision and drainage with bone resection. Pathology from the procedure showed A. faecalis to be the causative pathogen. It was pan-sensitive, and it was also noted that clear margins were not obtained. Therefore, the patient required oral Levaquin for 6 weeks with follow-up appointment with podiatry. While MRSA is the most common cause of osteomyelitis, it is important to consider secondary causes of osteomyelitis as well. As mentioned earlier, there are only 4 known cases in the literature of osteomyelitis caused by A. faecalis, and all of those patients were suffering from some sort of immunodeficiency. Considering our patient was immunocompetent, it makes us wonder if society's liberal use of antibiotics has pushed this organism to become more virulent in the process, as recent studies have shown some strains to exhibit antibiotic resistance, which is a new development since the bacteria was first isolated in 1896. It is also to be noted that while our patient had robust workups for a variety of ailments in the past, lab testing was not exhaustive. Thus, an undiagnosed condition causing transient or predominantly subclinical immunosuppression could remain.